Endometrium is very important in infertility. Endometrium is very important for conception to occur. Embryo can only implant in a properly formed endometrium. Sometimes endometrium becomes thin, it remains thin. In spite of all the efforts, the endometrium does not increase, and as a result, the pregnancy does not happen. Today, my dear friends, we will focus on thin endometrium. What is thin endometrium? What is the importance of endometrium in implantation? The definitions of thin endometrium, what are the causes of thin endometrium? What can be done for thin endometrium, the conventional treatments, the newer modalities, and what I do for my patients for thin endometrium. For pregnancy to occur, like I said in my all previous videos, endometrium is soil and embryo is seed. For implantation to occur, both seed and soil have to be of good quality. Embryo also needs to be of good quality. Endometrium also needs to be of good quality. And the embryo and the endometrium crosstalk should also happen. In all cases in whom implantation does not occur, out of them approximately 30 to 40% of the cases have got a embryo which is not of a good quality, while about 60 to 70% cases the endometrium is either endometrium is not good, endometrium is thin, the vascularity is not good, or the endometrium embryo crosstalk does not happen. Thin endometrium may be because of the inadequate growth of the glandular epithelium. It may be because of the impaired uterine blood flow or increase in uterine artery resistance. It may also be because of decrease in the vascularity, neoangiogenesis, or it may be because of decrease in vascular endothelial growth factors. Infertility by thin endometrium is a significant challenge both in IVF and in normal conception, and treatment for both varies significantly. See, if I am trying for a normal pregnancy, I do an ovulation stimulation follicle monitoring. At about the ovulation time, the endometrium must be minimum 7 to 8 millimeters. But if around the ovulation time, in spite of giving all the medicines, the endometrium remains thin, then there are not many things I as a doctor can do. But in IVF, things becomes relatively easy because I can segment the cycle. I can do a segmented or a frozen cycle IVF. First of all, I can form the embryos, and then by the hormone replacement therapy, I can form the endometrium. There are various modalities. We'll discuss it in both the halves. The treatment of thin endometrium we will discuss in a normal cycle, and in an IVF cycle we'll discuss in the second half. So endometrium basically contains mainly of two things. The superficial layer is of an epithelial layer, and beneath there is a mesenchymal layer. The growth of endometrium occurs in the first half of the cycle is primarily because of the estrogen. It causes proliferation, that means increase in the size of endometrium. And after the ovulation, once the endometrium has reached the peak thickness, the action of progesterone takes over. Progesterone makes the endometrium secretory. It improves the growth of glands. It improves the secretion of glands. And that is what it prepares the endometrium for an upcoming embryo, for an upcoming trophoblast to first oppose and then to attach. So the embryo implantation into the endometrium, initially it occurs by the apposition, and later on it occurs by the invasion of syncytiotrophoblasts and cytotrophoblasts from the embryo into the endometrium. So it is a complex interplay of hormonal, of immunological, of cytokines, and of vascular factors. So till now we have been talking about endometrium, but what exactly is thin endometrium? This is the anatomy of uterus. This outer wall is called as myometrium. The inner wall is called as an endometrium. Endometrium is basically the lining of uterus which is shed during every cycle. There are two cycles going on simultaneously. One is an ovarian cycle, one is a uterine cycle. From first 4 days in the menstruation, the whole endometrium is shed off. Then there is a proliferative phase in which, under the influence of estrogen, the follicular phase of an ovarian cycle, it correlates with the proliferative phase of the menstrual cycle. The moment the estrogen reaches to the peak, the main function of estrogen is to form the endometrium. Endometrium is a dynamic tissue which is basically an estrogen sensitive organ, and it responds to the rise in the levels of estrogen. So the moment along with the ovulation, the moment estrogen reaches peak, the proliferation of the endometrium reaches peak. And just about the ovulation, the progesterone starts rising. Progesterone makes the secretory component of the endometrium. So secretory phase of the endometrial cycle or uterine cycle, it correlates with the luteal phase of the ovarian cycle. And at about 7th day after ovulation, if the endometrium embryo is not implanted, then the hormones they fall off and the endometrium starts decreasing, and that's what the shading of the endometrium occurs. We measure a combined endometrial thickness in the longitudinal section, not in the transverse section, but in the longitudinal section. We see the uterus from side, and there are 5 layers of endometrium, or some people call it as a 3-layer endometrium: anterior layer, middle layer, and the posterior layer. The total combined endometrial thickness has to be 7 millimeter minimum, and anything less than 7 millimeter endometrium is called as a thin endometrium. There is something called as a refractory thin endometrium. If in spite of giving all the conventional treatment like estrogen, like aspirin, like sildenafil, like heparin, like pentoxifylline, like vitamin E, like omega-3 fatty acid, in spite of that, if the endometrium does not increase, then this is called as a refractory thin endometrium. And sometimes there is something called as an atrophic endometrium, in which the endometrial thickness is persistently less than or equal to 5 millimeter, in which the chances of pregnancy are very, very minimal. There is another entity called as an Asherman syndrome. Asherman syndrome is caused as a result of an excessive, aggressive curettage of the endometrium, leading to the damage of the basal layer of endometrium, whereby the anterior and posterior wall of endometrium gets adherent to each other at several places, and because of that adhesion, it prevents the chances of pregnancy, prevents the growth of endometrium. So will patient come to me and tell me, sir, I am having thin endometrium? In most of the cases, the patient is asymptomatic. There are no symptoms of asymptomatic. Possibly infertility, primary infertility, or recurrent IVF failure is one of the presenting symptoms of thin endometrium. Most of the patients might be having some light or scanty periods as a result of the less endometrium, but otherwise there are no symptoms of thin endometrium. So the most important thing, what are the causes of thin endometrium? It can be infective. Mostly any kind of endometritis, any kind of inflammation can lead to thin endometrium. It can be associated with inflammation like endometriosis, endometrial adhesions. These inflammation basically lead to the increase in interleukin 1 and interleukin 6, and as a result the endometrium remains thin. Tuberculosis, if we are in India, we have to always think about tuberculosis. Tuberculosis basically damages the stratum basal, thereby leading to the fibrosis, and the repair process is not occurring, and that is why there is a persistently thin endometrium. And once tuberculosis damages the endometrium, then nothing can be done to improve that endometrium. Then the only thing we can do is a surrogacy for that patient. Many kind of sexually transmitted diseases or pelvic inflammatory diseases can also lead to the permanent scarring of endometrium. Any intrauterine surgeries, excessive dilatation curettage, excessive removal of submucous fibroid, or if we are doing a laparoscopic or a intramural myomectomy, if it invades the cavity, then the part of the cavity, endometrial cavity, which is damaged, it gets repaired by fibrosis, and that is the area where the endometrium may remain thin. Endometrium can also be thin in the low estrogen conditions. Since I mentioned before in my video, endometrium is basically a estrogen dependent tissue. It is a dynamic tissue, and the thickness of endometrium varies according to the level of estrogen in the body. So in prepubertal females or in postmenopausal females, because the endometrium is estrogen is less in the body, the endometrium would be thin. In very few cases in which there is a hypogonadotrophic hypogonadism, that means pituitary is not working well, in those cases also the endometrium may remain persistently thin. It can be also because of various systemic conditions like diabetes, like hypertension. It can be also due to excessive use of past history of oral contraceptive pills or excessive use of clomiphene citrate. Clomiphene citrate, like I mentioned in my previous videos, it is a partial agonist and partial antagonist of estrogen. It occupies the estrogen receptors and it acts like a estrogen agonist at some place and estrogen antagonist at some places. In endometrium, it acts as an estrogen antagonist. So that is why and also because it has got a long acting action, it occupies those receptors for 2 months, 3 months, 4 months. And that is why if after giving clomiphene citrate for couple of cycles the endometrium does not increase, then you have to stop giving endometrium. Clomiphene anyway should not be given more than 3 consecutive cycles. Clomiphene in an ideal world we should not give more than 12 times in a lifetime to a patient. Inadequate blood flow can also cause endometrium to be less. So after doing all those Ramayana and Mahabharata about the causes of endometrium, the most important thing which you people want to listen is how to treat a thin endometrium. Like I mentioned before in my video, we will treat this subject of treating the thin endometrium in two ways. One is in an IVF cycle, frozen embryo transfer cycle, and one is in natural cycle. First of all, in a natural cycle, whenever we are doing an ovulation stimulation, we normally start from day 1, day 2, or day 3 of the cycle. Letrozole is usually started from day 2 or day 3. Clomiphene citrate we can start from day 2, day 3, day 4 till day 5 we can start. We normally give the ovulation stimulation oral ovulation tablets for 5 days, and we call the patient at about after 5 days of completion of tablet from day 10 to day 11. We expect at day 10, day 11, the follicle size should be somewhere about 14, 15, 16 millimeter. And if we give letrozole, the follicle growth is slightly slower, more physiological. If we give clomiphene citrate, follicle growth is more because of more high levels of FSH and LH. Around the time of ovulation, that is if the follicle is pre-ovulatory, say about 20, 21, 19, 20, 20, 21 millimeter size, and the endometrium has to be about minimum 7.5 millimeter should be there. If endometrium is not about 7 millimeter, then we call it as a thin endometrium. Now, how do I approach such cases? First of all, if endometrium is thin, I normally routinely start vasoactive agents in all my patients. For all of my patients, I give Ecosprin 150 milligram to every of my patient. Ecosprin is not a blood thinner tablet as many people would know. It basically is an anti-platelet aggregation agent. What I have found over my various years of practice as a gynecologist is that there are most of the people who are having primary infertility, and most of the females, they suffer from some degree of either antiphospholipid syndrome or lupus anticoagulation. Even if the reports are not totally suggestive, they have got some kind of an autoimmune factor, and most of the autoimmune factors lead to the formation of various small microthrombi, especially in the small vessels which are supplying the uterus. From uterus, radial arteries, spiral arteries, and the moment they go into the spiral arteries, the blood supply to the endometrium becomes less, and the moment the blood supply becomes less, the estrogen which is there in the blood of a female follicle secretes estrogen goes into the blood. From blood it comes to the spiral arteriole, and if that blood is not going to the uterus, that means estrogen is not reaching the endometrium, and as a result the endometrium may not form, or endometrium may not be of a good quality, or it may not be a triple line. So that is why in almost all of my patients, irrespective of any reports, I start 150 milligram aspirin. Earlier we used to give 75 milligram low dose aspirin, Ecosprin. Nowadays I have shifted to about 150 milligram. Most of the people have got fear that giving 150 milligram Ecosprin would lead to the increase in chance. It is a drug which is given in the cardiac cases. It should not be given in routine cases. But my experience in last 17-18 years has shown that aspirin does not lead to increase in episodes of bleeding. It possibly causes no harm whatsoever. Even if you are working in kitchen, you tend to get injured by a knife or by a needle, or you get some accident, the bleeding may not happen uncontrollably. Possibly, if normal bleeding time is 5 minutes, if a normal person has got a bleeding, you can press it for 5 minutes. If you are taking Ecosprin, instead of those 5 minutes, you may have to press for 7 minutes. Otherwise, it does not harm. I also use liberally vitamin E tocopherol in cases of endometrium. Vitamin E is an antioxidant. It reduces the free radical content. It also improves the uterine blood flow, and it has shown to improve the endometrial thickness. There are two things which I routinely use. Suppose patient has come for a second opinion to me, and the previous reports of previous follicle monitoring show that endometrium does not increase to more than 7 millimeter in spite of not using clomiphene citrate, in spite of using letrozole. Then whenever I am doing a ovulation stimulation along with clomiphene citrate or letrozole for first 5 to 7 days, I use sildenafil citrate Viagra. Yes, sildenafil citrate Viagra, either 25 milligram or 50 milligram per vaginally from day 3 to day 7 or day 8. What this sildenafil citrate does is it causes the vasodilatation of the uterine artery. It decreases the uterine artery resistance. Thereby, it vasodilates the uterine artery from uterine artery to radial artery to spiral artery, and as a result, the blood supply to the endometrium is increased, and thereby, whatever follicle I am forming along with because of clomiphene citrate or letrozole, that follicle which will give rise to an increase in estrogen, that estrogen may reach endometrium better, and that may lead to the better chances of endometrium formation. Pentoxifylline is also a very good agent for increasing the endometrial thickness. Pentoxifylline is given in the dose of 400 milligram either twice daily or thrice daily, especially in those patients who have got a documented history of thin endometrium in spite of doing all these things. If These are the vasoactive agents which we have used. We can also use L-arginine, which is a nitric oxide donor. I normally start L-arginine during the follicle monitoring during the ovulation induction. Along with letrozole or along with clomiphene citrate, we start 3 grams sachet 3 to 4 times a day. We can give up to 14 to 16 grams per day for about 5 to 7 days. Again, the purpose is almost similar to the sildenafil citrate. L-arginine is a nitric oxide donor. Nitric oxide is basically a vasodilator. It dilates all the arteries in the body, specifically the uterine arteries. The moment uterine arteries are dilated, the blood supply to the uterus is increased and also to the ovaries is increased. So as a result, the follicle stimulating hormone reaches ovaries better. It stimulates follicle growth better. The more the follicle growth occurs, the more the estrogen is produced. More estrogen goes into the bloodline, and from the blood it again comes back to the uterine artery, radial artery, spiral artery, and thereby the endometrium is increased. There is one another way of increasing the estrogen is to use HMG, human menopausal gonadotropin. HMG causes good growth of follicles. It causes multi-follicle stimulation. The more the number of follicles are there, the more the amount of estrogen is secreted in blood, the more endometrium occurs. But again, there is a very fine balance. The moment, the estrogen crosses the supraphysiological level, then it causes an adverse effect on the endometrium. So we need to increase the estrogen. Estrogen level should be 250 picogram per ml, but we also have to make sure that estrogen does not increase to so much that it causes an early maturation of endometrium, because during normal trial, normal pregnancy, timed intercourse or IUI, the moment the endometrium is advanced, then the pregnancy may not occur. There may be a embryo endometrial asynchrony, so the pregnancy may not occur. There are certain lifestyle changes which we always tell patient should be active, patient should be mobile, patient should be doing yoga. Surya Namaskar is the best yoga exercise which one should do. Surya Namaskar, what it does is it improves the various poses of Surya Namaskar. It improves the pelvic blood flow. It improves the blood supply to uterus. It improves the blood supply to ovaries. Even the use of the non-medical applications like use of hot water bag over the lower abdomen, it causes vasodilatation. Even any kind of a abdominal massage also leads to good endometrium. Some people have found out that acupuncture at various points of the abdomen can increase the endometrial thickness. While it is not my subject, but I personally believe that apart from medicines, apart from lifestyle, this acupuncture, even pelvic floor muscle exercise, Kegels exercise, they have found to improve the endometrial blood flow, uterine blood flow, the blood flow in the pelvic muscles, pelvic floor muscles, they improve. As a result, the endometrium has been found to improve. Any kind of athletes who are active, people who walk, people who play outdoor sports, they generally have got an overall increase in the blood flow. So for them, there are less chances of a thin endometrium. Recently, people have come up with 3 new techniques. One is granulocyte colony stimulating factor. One is platelet rich plasma, and another is an stem cell. For granulocyte stimulating factor, it has to be put intrauterine like an IUI. 1 ml injection is there, 300 microgram GCSF is available. If we put it in almost 90% cases, the endometrium increases by about 1.5 to 2 millimeter after 48 to 72 hours. That we normally reserve for either IVF patients or for patients in whom there is a chronically thin endometrium. I would make a detailed video of granulocyte colony stimulating factor on endometrium in second or third part of this series of thin endometrium. But what interests me most is stem cells. Stem cells are such cells, they are basically progenitor cells, and those cells, if they are put in the specific organ, they can convert to the cells or organ of that very type. Research is going on for the use of stem cells for increasing the endometrium. However, there are several critical challenges associated with the use of stem cells. Whether allogenic stem cells should be used or autologous stem cells should be used. Whether they should be derived from adipose tissue, they should be derived from bone marrow, they should be derived from endometrial menstrual blood, or they should be derived from umbilical cord or adipose tissue remains to be seen. Because the yield, the proliferative capacity, the immunogenicity, even the therapeutic mechanisms differ. We still do not know the specific cell surface markers. There are no standardization delivery methods, whether the stem cells have to be delivered by an intrauterine approach. Some people deliver by a subendometrial approach. Subendometrial approach is very difficult. You have to go for a cath lab. From cath lab, the catheterization has been done till the uterine artery, and from there the uterine artery, there stem cells have to be injected at the subendometrial level. Some people say you can do it hysteroscopically. It is difficult to puncture the endometrium and then do it. All these different methods, they have got different retention, different engraftment, and different therapeutic effects. Also, the studies, they still do not know the long-term effects of endometrial stem cells, transplanted stem cells, whether they lead to fibrosis, whether they lead to tumorigenicity or ectopic tissue formation. So stem cells is basically an area of research, although it can give good results, but still I would not recommend stem cells at this point of time. What I'm interested though is, and I routinely practice, is platelet-rich plasma. Platelets, as we all know, my dear friends, they are there in our own blood. Platelets contains alpha granules, delta granules. Platelets basically have got plenty of growth factors. And what people have found out, God has made platelets for a reason. The moment any injury, any inflammation occurs, why platelets go to that area? One important thing is to stop the bleeding so that platelets can gather at that area. They form a microthrombi or a thrombi or a clot formation, and thereby stop bleeding is the primary aim. But once the bleeding is stopped, the platelets at an injured or an inflamed tissue, they release the growth factors, and these growth factors help with the healing of that particular tissue. And this is the premise, this is the basis by which the platelets are used for thin endometrium. They contain various growth factors. They help in releasing and activating the fibroblast. They recruit leukocytes and thereby promoting the proliferation. It also improves vascularization, decreases the inflammation. When I do use platelets for patients with thin endometrium, first of all, I'll make a different video on role of platelet-rich plasma in infertility in gynec patients. But simple fundamental is take 10 to 20 ml of patient's blood in an ACD tube, acid-cited dextrose tube, mix it well, spin it. There are two types of spin which are needed to be done, hard spin and soft spin. Spin in a centrifuge machine for about 3500 RPM for about 5 to 7 minutes. There are three separate layers. The lowermost layer is a RBC. The topmost layer is a platelet with WBC. From that layer, you have to aspirate that layer, leave the RBC layer behind. Again spin it, take it into a different test tube. Again spin it. That is called a soft spin. Spin it for about 1200 to 1500 RPM for about 5 to 7 minutes. And then what you get beneath the test tube, at the bottom of the test tube, are whitish platelet. Remove the supernatant level of that, and whatever remaining portion is there, gently mix it well, 1 ml or 2 ml, and that can be injected inside the uterus like an IUI procedure. We do a PRP infusion, we infuse it slowly. Normally, I in my practice do infuse platelets around the time of ovulation or at the time of trigger, so that by the time of implantation, after ovulation, the implantation occurs after about 4 to 5 days, and platelets have been found to improve the growth of endometrium at least by 1 to 2 millimeter in about 2 to 3 days. So round about the day of SCG trigger, I do it. Advantage of platelets is A, it is autologous from the patient's own blood. B, there is no risk of tumorigenicity. There is no risk of infection. Patient does not have to go out. A simple procedure. It does not cost much. However, it's not as easy as it seems, because different people do different procedures. There is no standardized procedure. Some people use anticoagulation, some people do not use anticoagulation, some people use activation of platelet-rich plasma, some people do not use activation. It can be activated by calcium chloride or it can be activated by physical methods. Because there are no standardized protocols, because people, in an ideal world, the platelets need to be concentrated at least 5 to 7 times their initial concentration in the blood. Because there are no standardization protocols, at this point of time, ASHRE, that is European Society of Reproductive Endocrinologists, has said that PRP is not a therapy for thin endometrium. However, I have in my experience found that in patients in whom there is a recurrent implantation failure, in whom there is a recurrent IVF failure, or there is a persistently thin endometrium in which tuberculosis has been ruled out, platelet-rich plasma definitely does play an important role. And like I said, anyway, the endometrium is not increasing by whatever means we have done. So there is no harm in trying the patient's own blood, own platelets to increase the endometrium. One another thing which I do routinely in my practice is hydrotubation. Hydro means water, tubation means pushing the water through the tubes. I normally, what I do is around the time of ovulation, I just gently inject about 5 to 10 ml of simple normal saline through the cervix. From cervix it goes through the fallopian tubes and it comes out. I have found in my practice, it might be coincidental, but in patients in whom there is a persistently thin endometrium less than 7 millimeter, after doing hydrotubation, in about 1 to 2 days, the endometrium becomes about 8 millimeter, 7.5 to 8 millimeter. So this was about the increase in endometrium in a natural cycle, in an IUI cycle, or in a timed intercourse cycle. What about a persistent thin endometrium in a IVF cycle? Now, nowadays, most of the cycles are frozen embryo transfer cycles. By frozen embryo transfer cycles, I mean in one cycle, the embryo is formed, cryopreserved, wait for one cycle, and after one cycle, we start a endometrial preparation. For endometrial preparation, normally we start with estrogen valerate 2 milligrams twice daily from day 1 or day 2 of cycle. For 4 days, we start 2 milligrams twice daily, and then from 5th day onwards, we start 2 milligram either 3 times a day or 2 milligrams 2 tablet twice daily. So we reach up to maximum about 8, 10, 12 milligram per day. And as a result, the endometrium is found. We look for the transvaginal sonography. We look for the endometrium at about 10th or 11th day of cycle. If the endometrium is 7 millimeter, we wait for another couple of days. Again, examine the endometrium by doing transvaginal sonography. If endometrium increases to about 8 millimeter, it is fine. But still, after waiting for about another couple of days, endometrium does not increase, then we do some things to increase the endometrium. Like I have said that I normally, whenever I am doing a frozen embryo transfer cycle, from day 1, day 2 onwards, I normally put my patient on 50 to 100 milligram of sildenafil citrate vaginally to be used for 10 days. Sildenafil citrate will act as a nitric oxide donor. It will improve the vasodilatation of the uterine artery, thereby improving the blood supply. I also put my patients on Ecosprin, vitamin E twice daily. And in patients, there is a documented thin infection endometrium since the last many years. I also put my patients on pentoxifylline Trental tablet 400 milligram 3 times a day. I also give them arginine 1 sachet twice daily or thrice daily. There have been different studies which have been conducted which say either only aspirin or only vitamin E or only sildenafil or only arginine should be used. But I believe the patient is going to spend money on IVF, on embryo transfer, and by adding these medicines for 10 to 15 days does not add much to the money. It will hardly cost 1500, 200 rupees more. But even if after adding all these things, I can get 1 more millimeter of endometrium, then the chances of successful embryo transfer would increase. If after doing all this, after 14-15 days of estrogen, the endometrium does not increase, then we use our Brahmastra, we use our deadly weapon called as a GCSF, granulocyte colony stimulating factor. Novart, Gleichert and Barad et al. Have done various studies and they have found that intrauterine injection of 300 microgram granulocyte colony stimulating factor or GCSF with intrauterine slow infusion, and if you measure after 48 hours, there is a definite increase of 1 to 2 millimeter in most of the cases. In some cases in whom the endometrium does not increase after 48 to 72 hours, we can repeat this GSF intrauterine, and out of them in another 50% cases there is a increase in endometrium. However, I do not prefer giving GCSF twice. Simple one-time GCSF is enough. In my experience, if in previous cycle I have done endometrial scratching for all those patients in whom the endometrium does not increase, there is a history of multiple IVF failures or history of persistent thin endometrium, I do another modality called as an endometrial scratching. This is a deliberate scratching, deliberate injuring the endometrium in previous cycle of embryo transfer, which increases the growth of endometrium in this cycle. However, the recent recommendations of Asherman and ASRM again are not in favor of routinely doing endometrial scratching. How to do endometrial scratching, when to do endometrial scratching, what are the results, this all I'll make another video detailed, specifically focused on an endometrial scratching for building the endometrium for thin endometrium patients. Even after doing all these things, if endometrium does not increase, endometrial thickness is not the only criteria. If there is a 5.5 millimeter endometrium, but we have done all these things and there is a good vascularity, there is a triple line endometrium, the endometrial pattern is good, then we go ahead with the transfer. There are certain futuristic materials which have come in the market. There have been strategies which have combined mesenchymal stem cells with decellularized scaffolds, which have shown great potential in repair and functional regeneration of endometrium. But these are mainly in the preclinical studies. The clinical studies have not been done so far. These materials, they mimic the in vivo microenvironment. They provide the physical support for cell attachment, proliferation and differentiation, and enable the controlled release of growth factors. These biomaterials, they're still in research. Possibly in next 5 to 10 years, they may come into good effect. But for now, plenty of hydration, plenty of oral antioxidants, plenty of physical exercise, avoidance of diet in any which is rich in refined carbohydrates, an anti-inflammatory diet, yoga, especially focusing on the Surya Namaskar, which focuses on the pelvic floor muscles exercises. They are good lifestyle and dietary measures to improve endometrium. And like I said, I use aspirin, like as they say in Hindi or Gujarati, chana mamra. I use aspirin, Ecosprin, low dose aspirin 150 milligram in each and every of my patient, irrespective of whether the patient has a documented history of systematic lupus erythematosus or antiphospholipid syndrome or not. Very rarely, if patient is positive for thyroid antibodies, patient is positive for antiphospholipid syndrome, we can use methylprednisolone also to increase the endometrium. One thing I forgot is hyperprolactinemia. If prolactin is high, prolactin basically acts as an anti-gonadotrophic, so it acts against estrogen in females, it acts against testosterone in males. It might, more prolactin may lead to slight impotence or decrease in sexual activity by males. Same is in females, it acts against estrogen, so hyperprolactinemia needs to be ruled out. Hyperprolactinemia treatment is simple. You just give a simple cabergoline tablet to a 0.25 milligram or 0.5 milligram once or twice weekly depending upon the level. But routinely prescribing cabergoline for hyperprolactinemia is not good, because body needs some level of prolactin for conception to occur. So this was my short video on thin endometrium. In next video we will talk about the role of GCSF for thin endometrium, and after that we will talk about the role of and current status of endometrial scratching, endometrial injury as a means to improve thin endometrium, especially in IVF or IUI patients. Request to please like the video, to please share the video, and to subscribe to our channel. Namaskar, bye bye.